Hello, everyone. My name's Frank Stichter with Strategic Health Plan Consulting. And I want to talk to you today about a new health plan strategy to dramatically lower claim costs and the costs of your health plan for your employees. The status quo is no longer working. The way we've always purchased health insurance in the past, going out for RFPs, trying to determine who has the greatest discounts, what to do with pharmacy. All of it is not working any longer, and it's unsustainable as rate increases continue, and it's unaffordable for employees as well. I've been in the healthcare benefits business for my entire career. I worked for a couple of large insurance agencies, regional insurance agencies. I know how insurance brokers and insurance companies operate, and I got tired of it. Of the way they operate. My father was an attorney, and he told me, for this business, if you put everybody's interests ahead of your own, everything will work out just fine. And while there are terrific brokers and agencies out there, I can tell you that not all of them subscribe to that statement. So our goal is to identify and quantify opportunities in your own plan, within your plan, that can create some compelling savings, and doing it without changing benefits to employees, because anybody can lower costs by raising deductibles and out-of-pocket expenses. You could argue that our care is the best in the world, but you can't argue it's the most costly. Professor Reinhardt from Princeton University, you can see that we're the sloppiest purchasers. Back in 2013, Time magazine devoted an entire issue, first time ever, an entire issue to why medical bills are killing us. And we've all heard about Warren Buffett's efforts to lower costs. But usually, health insurance is the second or third highest expense on a company's P&L next to payroll. Insurance companies lead us to believe that they have huge discounts, but what I'm going to show you is that they're on very highly inflated and egregious pricing. Health insurance premiums and the amount workers contribute to premiums are the top two lines you see here, and the bottom two lines are workers' earnings and overall inflation. I wrote a white paper years ago on affordability and sustainability. The affordability side of it is that employees have a great deal of angst about their ability to afford insurance, either out of their paycheck or when they have a claim. The sustainability side has to do with the rule of 72, and that the sustainability of an employer to be able to continue to offer these benefits. I don't know if you're familiar with the rule of 72, but it's Albert Einstein, and it's the rule of compounding interest. So if you take an interest rate divided into 72, the result is the number of years it takes money to double. So if you were getting a 9% increase in your health insurance every year, in 8 years your costs have doubled. So when you apply that rule, we're in a perfect storm that has no good ending. And the reality is, too, that you can't give meaningful wage increases and afford increasing insurance costs. A couple of tidbits there. I mean, essentially, that's the bottom line. Employees take a pay cut every year as premiums rise faster than wages. Medical bills are clearly a problem. The largest cause of bankruptcies, over 1/2 of items on credit reports are medical debts, and 43 million people have unpaid medical debts. It's getting even worse now. As a broker, a traditional broker, the mission was when my clients got an increase, they were always trying to get a better quote. You know, who can pay it faster and cheaper than the next guy? The biggest piece of the pie, the cost pie, are claims, but everybody focuses on the transactional side, the fixed cost. So where stop loss might be 10%, you know, the TPA might be 5%, a network might be 5% of the total cost. Brokers traditionally focus on who can pay it faster, who can pay it cheaper, who has the best network, but they avoid the biggest piece of the pie, and that's claims. And when insurance companies purport PPO discounts, that's what they're looking at. So you never know what the discounts actually are, and you never know what's been negotiated or what a provider is charging. Insurance companies call that proprietary, so do the hospitals. You never know what you're buying. This happens to be a map of the highest markup states for Medicare in the country. So this is the average markup. Every hospital in this country has what's called a charge master. Everybody's charge master is different because they offer different services. But a charge master is a voluminous file of everything they offer you and me when we walk in the door. It's everything from ibuprofen to the ICU and its related price. Every year, the hospitals have to file a report to the Centers for Medicare and Medicaid what their actual cost is. They also include their charge, but every year it's signed off by the CFO because it in turn is the report that it's in turn the report is the basis of their reimbursement from Medicare. So because it's public money going in, you and I all pay taxes to Medicare. It's public money coming out. It's public information, and most people don't know how to obtain it, but it is public. So you can see what the average markup for hospitals in each state are over what they get from Medicare. A friend of mine used to be a CFO at the hospital here in Colorado. He's now in Wyoming. And I asked Brian one day, what are your margins on just Medicare? Not Medicaid, not commercial insurance. I don't want to hear about your bottom line and what you provide to the indigent, but what are hospital markup or hospital profit margins just on Medicare alone? And he said, Frank, it depends on a lot of factors. Your management team, are you profit, not for profit? Are you a critical access hospital in Colorado? Are you inner city in Philadelphia? But he said the average profit margins on Medicare alone are between 5.5% and 9.5%. I'm sure there's exceptions to that rule, but if you look at these markups on top of a 5.5% to 9.5% profit margin, you can see that our prices are way out of line. So I have this circled, everybody, you still counting on insurance companies to save you money? Well, look at the profits that they've made since 2014. I don't have the other recent ones up, but over here you can see that employer-based coverage is the major profit center for insurance companies. And in fact, if we had all bought stock in what we call BUCA, Blue Cross United Cigna Aetna, back when Obamacare first came out, you wouldn't be watching this and I wouldn't be explaining this because we'd all be retired. The profits are just continuing to go up and up and up. So health care is the only thing we buy in this world that we don't know what the price is before we have the service. We find out 60 to 90 days later once we get a bill. We don't buy a car that way. We don't buy groceries that way. We don't buy clothes that way, yet we buy health care that way. So $64,000 question, shouldn't a health plan purchase services in the same transparent manner that you buy raw materials, supplies, and services? PPO contracts with providers are not transparent. When an insurance company or a PPO goes in and negotiates a PPO discount, it's off of that charge master, what the billing is, what they want to bill. Remember I said it had everything, that charge master has everything that they offer when we walk in the door and its price. So when a PPO comes in and negotiates a discount, I call it top-down pricing, whereby you have the charge master and the discount off those bill charges. But what you don't know is, because hospitals can raise their prices anytime they want. There's no laws, no rules, no regulations, no nothing in this country about what hospitals can charge. So when an insurance company used to come to me and say, hey, Frank, sell our program, our PPO, we have the best discounts going. My cynical response was, discount off of what? Discount off of what? You may have negotiated a big discount, but what you don't know is the CFO just raised the price to offset it. To get to where we're really going with this about repricing claims, let's just take this first one, item A, hospital hysterectomy, where a hospital would charge a little over 20 grand for that hysterectomy. Let's say the insurance company had a 50% discount. So your plan paid $10,131. The whole insurance and hospital billing system is built off of what's called a universal bill, or a UB. The universal bill is like the old Ma Bell telephone bill, where it would show local charges, long distance charges, taxes, total, bingo, that's it. So the discount is applied to that universal bill. Well, when we reprice a bill and adjudicate a claim, we go off an itemized bill, an IB. So there's a forensic audit, and then we reprice, which I'll describe in a minute. But you can't get a big enough discount from a PPO to get down to $4,300. So I'm going to explain a little bit more about that, but hold that thought. You don't have to treat healthcare differently because you are a planned fiduciary. And under ERISA, federal law, planned fiduciaries are responsible for paying reasonable charges. How can you be a reasonable planned fiduciary when you don't know what you're buying? You're using other people's money, your employees, to purchase health insurance, but you don't know what providers are charging. You don't know what hospitals have negotiated. You know nothing. So the answer is, you can't be a responsible planned fiduciary under the current status quo arrangements. Here's a couple of other studies that we've done on groups. We can just talk about the first one there, the 1900 life distributor, 22 million, over $22 million of bill charges. They're per employee per month cost. This is an average composite monthly cost of $444. We dropped it down. That's after the PPO, by the way. We dropped it down to $313, which is an additional 29.5% reduction over and above what their PPO could produce. When they do the universal bill, the UB, and the discount off of bill charges, they don't audit a claim. So you really don't know for things that might be duplicated, might not have occurred, that sort of thing. So using the UB doesn't permit this kind of savings. Home Depot, in some of their selected cities, their employee per year cost was, back in 17, was about $5,000. We were able to drop it to about $4,100, or an additional 16%, excuse me, savings over their PPO. And we're not just talking about you, the employer. So in this example, under a PPO with a plan over here of $6,000 deductible, out of pocket of $12,000, 80/20. Under this particular claim, an employee would have paid under the PPO $11,152. Instead, they paid $4,471. So everybody wins. It's not just your business, but this makes it affordable for your employees and sustainable for your business. Let me give you a couple of real life examples here. This is a person who was admitted for a mini stroke, and they were billed, as you can see, $67,373. Well, when we got the itemized bill, there was a $20,000 charge for intensive care for a burn unit. This was a mini stroke. This was not a burn. And your plan, let's just say you had a 50% discount, your plan would have paid about $34,000, 50% off the 67. And in fact, this employer paid $7,952. That's a huge, huge drop, and it never would have occurred without the audit. Here's another one. This is a child with sleep apnea and tonsillitis. The bill came in at $78,000, but again, a 50% discount off the UB, you're talking what, $39,000 you would pay. But in this one, there was a double dip. They added $34,000 for the removal of tonsils, when in fact the palate repair includes tonsils removed. So again, until the audit was done on the itemized bill, you as an employer would have paid significantly more than the $2,351 that ultimately got paid. Last one here. This is really egregious. This was a hernia repair, and the bill came in at almost $619,000. Well, when we got the itemized bill, you can see here this line item down here, there was a charge of almost $500,000 for anesthesia. Now you can say that somebody hit an extra zero. You could say that well, a number of things, but this is really egregious. But if this has been, again, paying off a universal bill, you would have paid half of the 618, let's call it 309,000. Instead, this employer paid roughly 6,200. Again, it's only because we're using the itemized bill and the not the universal bill. So this is what I call it top-down pricing. So let's just say you had a $100,000 claim, 50% discount or thereabouts takes it down to $47,500. What we do in this repricing exercise, in addition to the audit, is we do bottom-up pricing. The bottom is Medicare, and what the plan pays is the greater of the reported cost to the Centers for Medicare and Medicaid, or 120% of Medicare. And the reason we use both metrics is that sometimes Medicare doesn't cover the cost. So we want to make sure that the hospital gets a fair and reasonable profit. So in this case, the plan paid 140%, but our price that we paid instead of $47,500 was $22,700. So it's the audit and it's the repricing based on cost and Medicare that account for these large reductions. The other way you can save money is through a pharmacy benefit manager, or a PBM. So there's a lot of different ways that PBMs make money. And I'm just going to go through this quickly, but the two big ones are spread pricing and rebates. So spread pricing is whereby the PBM goes and negotiates a discount, a price, just like a PPO does, for a particular drug. They negotiate that with a drug manufacturer, but the spread pricing comes into where they negotiate one price that they buy it for, and you and your plan are paying for it at a different price. That's the spread, and they keep the spread. The other is for rebates. And what happens here is that when they negotiate these drug prices and the selection of drugs that go into your formulary or your preferred drugs, there are rebates available to them. So the question becomes, who's keeping the rebate? Is it the PBM? Is it the insurance company? Is it your broker? Or are you getting some? Now, I can tell you for a fact, I've sat across the table from a PBM and they've said, Frank, how much of the rebate do you want? 25%, 30%? We're going to keep a little and we're going to give the rest to the client. So you may be getting rebates, but again, the question is, are you getting all the rebates? So what we deal with in a PBM is no spread pricing. Whatever's negotiated by the PBM is what you pay. They only make their money in a small administrative charge. That's it. And we also guarantee 100% of the rebates back to our clients. And these amounts for the spread pricing and rebates are significant. I mean, significant. Just to give you an idea, again, on specialty drugs, you know, these drugs aren't going down. I can tell you Humira's now up to $65,000 a year. Of course, that's the most popular advertisement for prescriptions on television. They don't tell you about the price, but we have a program where we can get over 1,700 specialty drugs at little or no cost to the member and at little or no cost to the plan. We're not just talking about discounts here, we're talking about little or no cost whatsoever. So let me ask you this question. Who on your healthcare team has an incentive for your costs to go down? Well, let's identify the team. Doctors, hospitals, pharmacy, your insurance company, your broker, your consultant. The reality is that no one on your team has an incentive for your costs to go down. In fact, they all benefit when your costs go up. Hospital makes more money, doctors make more money, your stop-loss carrier is pulling in more premium, PBMs are collecting more, and your broker, if he or she taking a commission and you get a rate increase, they just got a pay raise. So no one on your team has an incentive for your cost to go down. So why would they be interested in changing the status quo? So if costs are going to continue to increase, what are you going to do about it? Your healthcare team is going to push back because no one wants change. But you're never going to save 20, 30, 40% or more doing the same things you've been doing. Providers certainly aren't going to change. They have no incentive there. They like where it is. Brokers and insurance companies, their interests are not aligned by yours. When was the last time your broker made a recommendation about your health plan as if it were their money? HR, you know, God love them. They're very, very important in communication and support and rollout and all that. But it's a lot of people think it's too much work. Status quo is too easy, and they don't have a financial stake like CFOs do, or CEOs, or business owners, presidents. So you can do the same things you've done in the past and continue with status quo. You can keep shifting to employees, cost shifting. You can raise everybody's deductibles, copays, etc. You can take more out of their paycheck. You can change insurance companies who tell you they've got bigger discounts. You can put in a wellness disease management plan. I have some history here and some experience. I was a co-founder and partner in a disease management program. They do work, but limited success. You can change PBMs. You can put in tools for transparency, or you can take me up on my offer. And that's what you saw on the website. What I do is I do a complimentary financial feasibility study for my clients and companies that are interested in this. It's confidential, totally confidential. No one knows it but you and me and your insurance company, not your broker. And in order to do this, I can do it if you give me permission to gather the data I need. You're certainly welcome to get it yourself. I can send you the laundry list. But if you give me a letter of permission, I can keep this out of your hair. This would stay in your office. It's only between the CFOs and the financial people. It's strictly a financial evaluation. I don't want to infringe on any of your time or your duties. We're not changing your current broker or consultant. There's no obligation. I would hope that if you take me up on this, once you see it, you would make those changes with me. But what we're going to do is we're going to reprice the pharmacy and medical claims based upon what I've told you about bottom-up pricing and a different PBM. And we're going to determine what that financial impact is. We can actually quantify the savings that you could have had during the time frame of the data. So, as I said at the very beginning, our goal is to identify and quantify opportunities within your plan that create compelling savings without cost shifting or changing benefits to the employee. So that's a big assumption, no change. I will provide you with a written report with observations and recommendations for you to consider, and it's quantifiable. It's absolutely quantifiable. But if we can't create compelling savings for you, there's no reason to do what my clients have done. So the idea is to quantify this to meaningful numbers so that you can determine what's the best way to go. Here's one. This is a feasibility study that we did on a publicly traded 2,200 life group. They were in 20 states. Their medical spend was about 32 million, another 5.6 million of pharmacy. What we were able to do is in the medical plan reduce their cost by almost 7 million, 1.6 million by changing PBMs and no spread pricing and 100% rebates, and then took all their drugs, the specialty drugs that people were taking, and we were able to reprice that, and that was another 1.6 million for a total of $10.24 million, or a savings of $4,655 per employee per year. So $10 million is nothing to sneeze at. And I remember in this corporate boardroom presenting this to the entire company, their 8 divisional presidents, 8 divisional HR people, the CEO, the CFO. And I was sitting down at one end of the table on the side. The CEO was sitting at the head at the far end. And he looked around and he said, "Anybody in this room know how we can save $10 million? And simultaneously, everybody dropped their head to look at the table. And he said, I didn't think so. We need to look into this." Here's another one. This is a privately held international electronics firm, 1,500 employees in 18 states. Their spend, as you can see here, 23 million in medical, almost 6 million in RX. And we were able to drop their costs by $6.5 million, or $4,369 per employee per year. Again, there's no cost to look at this feasibility study. There's no obligation, but at the end of the day, you'll know whether there's a compelling opportunity and reason to move forward or investigate it further once you have the report. So what I have is a savings estimator. And what we do is, once we have this whole report put together, let's just say, for example, your costs are a little over $12,500 a year. You got 2,000 employees. That's $25 million spend. Our average savings for our clients is 28.5%. You could see by those last 2 case studies, it was more than that. But the average savings for the clients is roughly $3,600 with your per year. And if you had 2,000 employees, that's $7.1 million of savings. So we're dropping the $25 million spend to $17,875,000, or dropping the per employee per year spend from $12,500 down to $8,900. So the steps really are to give me a letter of permission, or if you want to gather the data, you can. It does take time. Sometimes I don't get the right data, or I don't get the complete data, so I have to go back. But needless to say, I need permission in order to do that. We'll reprice all the claims, the medical and pharmacy claims. I'll put together a written report and present the results. If you decide to implement, we can move ahead with a timetable and do employee communications, go live but it's, again, your call. So a lot of great testimonials. You'll see a couple of videos and a couple of written testimonials on the website. But I sure would like to show you what we can do. I think this will clearly make it more sustainable for you as a business and more affordable for your employees. You can reach me. You'll see on the website my email address, frank.stichter@strategichpc.com, or you can feel free to call me anytime. My office number is 970-349-7707. Thank you. Stay safe, stay well. Talk soon.